Welcome to the Deep Dive, the show that cuts through the noise and gets right to the heart of what you need to know. Today, we're plunging into a major global health challenge. It often flies under the radar, but honestly, it poses an immense threat to all of us. Antimicrobial resistance, or AMR.
Yeah, it's often called the silent pandemic, and for good reason.
Yeah.
I mean, just imagine a world where common infections, things we barely think about now, become untreatable.
Right.
That's basically AMR. It's when microbes, bacteria, viruses, fungi, parasites, they evolve, they outsmart the drugs that we rely on to kill them. So suddenly, a simple cut, maybe routine surgery, even pneumonia, could become deadly again.
And here's the really frustrating part, the kicker. Most countries, something like 88%, have actually put together national action plans, NAPs, to fight AMR. Sounds like progress, right? But the problem is, a huge number of these plans are just sitting there, largely unimplemented. And maybe worse, only a tiny fraction, just 11%, have actually locked down the funding they need.
Exactly. It's like having, a detailed map for this critical journey, but absolutely no car, no fuel to even start.
So we know it needs doing, but the how and the why it isn't happening effectively in so many places. That's the real nut to crack.
That's the core challenge, yes.
And that's precisely why our deep dive today is looking at this really interesting research protocol called SPAARTA. That stands for Systems Policy Analysis for Antimicrobial Resistance Targeted Action. What's SPAARTA trying to achieve? What's its big mission?
Well, SPAARTA's goal is pretty ambitious. It's aiming to provide this innovative, systematic way for countries to genuinely compare their AMR strategies.
Okay.
To understand what's actually working, what isn't, refine their actions, and then move forward with, let's say, more effective NAPs. They call them version 2.0.
And it's not just about the medicines or the microbes themselves, is it? It's looking bigger picture.
Exactly. It's about looking at those broader systemic factors, things within a country that might block progress or, actually boost success in tackling this crisis.
So this deep dive is really about how this study is trying to crack the code on what makes an AMR strategy truly effective.
That's the goal.
All right, let's start by just reinforcing that core problem of AMR. We've said it's microbes getting resistant to drugs. How does this growing threat really hit society, beyond just making infections harder to treat day to day?
Well, the impact is just profound because it threatens the bedrock of modern medicine, really. Think about our ability to treat common things like pneumonia, UTIs,
right,
or even complex procedures, surgery, organ transplants, cancer chemotherapy. These all rely heavily on effective antibiotics to prevent or treat infections. If those fail, the risks skyrocket. It's quietly chipping away at our medical safety net.
Okay, so we know 88% of countries responded to that WHO Global Action Plan back in 2015. They created these NAPs, they're sort of version 1.0s. But like we said, implementation, funding, major hurdles. Only 11% have the cash. What's the key insight SPAARTA brings to this specific problem? The gap between plan and action.
Yeah, what's really crucial here, and what SPAARTA highlights, is that it's not just about having a policy document. It's about digging into why some countries manage to make real progress, while others just seem to stall.
Okay.
And that means looking beyond just the specific AMR policies themselves. It means capturing those broader, systemic, country-level factors, things like governance, economic stability, infrastructure, all the things that can either hold back or accelerate success.
That makes complete sense. It's the whole context.
Yeah.
And the study specifically uses a One Health approach.
Right.
Can you break down why looking at human, animal, and environmental health together is so vital for AMR? Maybe give an example.
Absolutely. One Health is critical because AMR doesn't respect boundaries.
Yeah.
I mean, think about it. If you only focus on antibiotic use in human hospitals,
Right.
but meanwhile, antibiotics are being used extensively in agriculture, maybe ending up in runoff. Or perhaps pollution from pharmaceutical manufacturing is leaching resistant bacteria or drug residues into rivers. You're only seeing a small part of the picture.
You're missing huge drivers of the problem.
Exactly. A One Health approach recognizes this deep interconnection. Human health, animal health, the environment, they're all linked. For example, improving sanitation in a community reduces diarrheal diseases in people.
Okay.
That means fewer infections, which means less need for antibiotics in the first place. That reduced use then lessens the pressure driving resistance. It's all connected in a cycle.
That holistic view feels absolutely essential. So how does SPAARTA go about systematically unpacking these really complex strategies? I understand it's a pretty rigorous three-phase approach.
That's right. It starts by meticulously mapping out the landscape, what's actually out there.
Okay, let's dive into phase one then. The deep dive into policies and interventions using textual analysis. How did they actually approach mapping this policy landscape? What did that look like?
So this phase was really an in-depth qualitative appraisal, looking at the quality and type of existing policies and interventions. Think of it like creating a massive detailed inventory. Cataloging all the strategies countries have tried or are currently trying to tackle AMR. To do this, they conducted this huge literature search, all languages, from 2000 right up to 2024,
Wow.
pulling from peer-reviewed journals, policy documents, gray literature, global reports, national reports, even state-level progress reports. A vast amount of information.
That's comprehensive.
And importantly, this data was then validated. They checked it with global experts and, crucially, in-country experts to make sure it was accurate and reflected the reality on the ground.
So they gathered all this information. Which countries were actually included in this initial mapping?
The initial sample was 17 countries, and they were chosen purposively, meaning deliberately selected to represent all the WHO regions and also key emerging economies.
Okay.
So this included nations like Brazil, Russia, India, China, South Africa,
Right.
but also others like Bangladesh, Colombia, Ghana, Indonesia, Kosovo, Malawi, Pakistan, the Philippines, Saudi Arabia, Uganda, and even the UK was included for comparison.
So a real mix of contexts.
Exactly. That diversity is key to making sure the insights are broadly relevant.
That's a really wide net they cast. And they didn't just collect these documents, right? They used specific tools, frameworks to analyze all this information systematically. I heard about two key ones.
Yes, that's right. To really code the interventions and make sense of it all, they use multidisciplinary frameworks. The first one was the Expert Consensus for Implementation Research Framework, usually just called ERIC.
Eric, okay.
ERIC is essentially a structured list of 73 distinct implementation strategies, things you can do to make a policy happen. These are grouped into 9 broader categories, like adapt and tailor to context, use financial strategies, engage consumers.
73 strategies.
Yeah, it's incredibly detailed. What's powerful about ERIC is that it gives researchers and policymakers basically a menu, a blueprint of almost every known strategy for getting health policies actually implemented effectively.
So they could see not just what countries were trying, but how comprehensively they were approaching implementation.
Precisely. Or maybe where the gaps were. What crucial steps might be missing from their approach?
That sounds incredibly useful. And what was the second framework they used?
That was the PESTELI framework. It stands for Political, Economic, Sociological, Technological, Environmental, Legislative, and Industry Factors.
PESTELI, got it.
This framework helps assess the broader macro environment. Basically, it asks, what are the big picture external forces shaping a country's ability to actually do its AMR strategy?
So things outside the health sector, almost.
Exactly. Things like government stability, the economic climate, technological infrastructure, environmental regulations, the legislative landscape, even the influence of relevant industries. It helps map that crucial context we talked about.
So using these frameworks, they really broke down each intervention they found. What kind of specific details were they coding for each one?
They got really granular.
Yeah.
For each intervention, they coded, the level of implementation. Was it a big national macro-level policy or a regional meso-level program or a very local micro-level thing in one hospital? Also, its maturity. Was it just an idea, newly developed? Was it actively being implemented? Or had it actually been evaluated to see if it worked?
Ah, important distinction.
Very. They also coded common barriers and facilitators, what helped it succeed or what made it difficult. The specific setting, like a hospital, the secondary care, a community clinic, maybe social care. The target audience was it aimed at doctors, patients, the general public, farmers.
Right.
The theme like AMR surveillance, antimicrobial stewardship, public education, R&D, infection control, and even the specific pathogen type it was trying to address, if relevant.
Wow, that is incredibly detailed. It allows for some really fine-grained analysis, doesn't it?
Absolutely. It builds a really rich, multidimensional picture of each intervention.
Okay, so after meticulously mapping that whole policy landscape qualitatively, how did SPAARTA then move towards, well, the hard numbers? What was the focus of phase 2, the longitudinal quantitative analysis?
Right, so phase 2 shifts gears. This part is about assessing the potential impact of all those country contextual factors and the AMR interventions themselves.
Impact on what specifically?
On 2 key outcomes. Firstly, antimicrobial use, or AMU basically, how many antibiotics are being consumed. And secondly, the actual AMR burden, how much resistance is out there. It's connecting the policies to the real-world problem metrics.
And for this phase, they zeroed in primarily on the BRICS countries, right? Brazil, Russia, India, China, South Africa. Why that specific focus?
Yes, the BRICS focus is strategic. These 5 countries are huge. Together, they account for about 45% of the entire global population and roughly a third, 33% of global GDP.
Wow, significant numbers.
Immense. So analyzing them provides a really vital benchmark, not just for comparison among themselves, but also for understanding trends within their regions, and importantly, for anticipating challenges and solutions for other major economies that will face similar AMR pressures down the line.
Makes sense. Where do they actually get the data to, crunch these numbers? Tracking antibiotic use and resistance across time for these huge countries sounds challenging. It definitely is. They pulled data from established, reputable sources. Global health indicator repositories, places like the WHO's Global Health Observatory, World Bank open data, OECD data were available, and also international and national surveillance networks specifically designed to track AMU and AMR. It's about leveraging existing, validated data streams as much as possible.
So how were AMU and AMR actually measured in a consistent way that lets you compare across these different countries and over time?
Good question. For AMU, antimicrobial use, they used a standard metric, the total defined daily dosage, or DDD, of antibiotics dispensed to human populations. They aimed for data covering at least 20 years.
DDD, right? That standardizes the dose.
Exactly. It gives a comparable measure of consumption volume over time. For AMR, the resistance part, they looked at the reported percentage of resistant isolates for specific high-priority bug-drug combinations.
Which ones?
The ones the WHO flags as critical and high priority. Think carbapenem-resistant Enterobacterales, or third-generation cephalosporin-resistant Enterobacterales, MRSA methicillin-resistant Staphylococcus aureus.
The really dangerous ones.
Yes, the superbugs that pose the biggest immediate threat because our treatment options are becoming so limited. They did acknowledge a limitation here, though.
What's that?
Most of the available AMR data, especially historically, comes from hospitals, secondary, or tertiary care, which means it might overrepresent resistance seen in sicker hospitalized patients and potentially underestimate the true burden of resistance circulating out in the community.
Ah, okay. A potential bias to keep in mind.
Definitely.
So, to really understand the impact of policies and context on these AMU and AMR numbers, they use some pretty sophisticated statistical methods, right? Econometric and machine learning approaches.
Yes, this is where the serious analytical power comes in. They didn't just look at simple correlations. They employed several advanced techniques.
Like what? Can you walk us through a couple?
Sure. They use things like beta regression models. These are particularly good for analyzing outcome variables that are proportions or percentages, which is exactly what AMR resistance data often is, like, the percentage of isolates resistant to a drug.
Okay, fits the data type.
Exactly.
Yeah.
Then they use something called extreme bounds analysis, or EBA.
Extreme bounds analysis, what does that do?
Think of EBA as like a super robust sensitivity check. It tests how stable the relationship between an independent variable, say, a specific policy or a contextual factor, and the outcome, AMU or AMR, is.
How stable?
It checks if that relationship holds up even when you change other variables in the model or consider more extreme possibilities. It helps identify determinants that are consistently associated with the outcome across many different model specifications. It tells you which findings are really solid.
So it boosts confidence in the results.
Right.
What about Bayesian model averaging? That sounds complex.
It is, but the idea is quite elegant, actually. Bayesian model averaging, or BMA, tackles the problem of model uncertainty. Often in statistics, there isn't one single perfect model.
Right.
BMA gets around this by not picking just one model. Instead, it considers a whole set of plausible models and then averages the results across them, weighted by how likely each model is.
So you get a more balanced picture.
Exactly. It gives you more holistic and robust estimates because it's not overly reliant on the assumptions of any single model. It's like getting a consensus forecast from a committee of good models rather than trusting just one.
Okay, that makes sense. And the last one mentioned was Bayesian networks. How do they fit in, especially with predicting things?
Bayesian networks are a fascinating tool for machine learning. They're used here primarily for causal inference. They help visualize and quantify the probabilistic relationships between different factors.
Causal inference. So trying to see what causes what.
Precisely. They help identify potential key risk factors and the pathways, the chains of influence that lead to changes in AMU and AMR. And crucially, they can be used to predict how different combinations of policy mixes might impact a country's situation.
Like running simulations.
Kind of, yes. It allows policymakers to explore what-if scenarios. What happens if we strengthen surveillance and implement stewardship programs? How might that shift the needle compared to doing just one? It helps find those potential causal levers.
That sounds incredibly powerful for decision-making. I also saw they used HIV/AIDS prevalence data in parallel during model development. Why do that?
That was quite a clever methodological step. They anticipated correctly that consistent long-term AMR data across all the countries would be patchier, especially going back years, compared to data for other major global health issues like HIV/AIDS.
Okay.
So by using the more complete and consistent HIV/AIDS prevalence data as an outcome variable in parallel while developing and refining their complex statistical models, they could essentially train and validate the models on a robust data set first.
Test driving the models, basically.
Exactly. It ensured the analytical machinery was working correctly and was reliable before they applied it to the potentially less consistent, more challenging AMR data. It improved the quality of the final AMR analysis.
Smart. And I understand this whole quantitative phase 2, is being rolled out in stages.
Yes, that's right. The initial focus, as we discussed, was on human health in the BRICS countries. That's sort of phase 2A. The plan is for phase 2B to expand the analysis.
How so?
To bring in the environmental and animal health sectors, fully embracing that One Health approach and the quantitative analysis too, and potentially include data from other case countries beyond the initial BRICS set. It's an ongoing iterative process.
Okay, so phase 1, map the policies. Phase 2, crunch the numbers on impact. Now, phase 3, bringing it all together so people can actually use it. What's the main output here?
The main output of phase 3 is the development of an interactive dynamic dashboard. They're building it using Tableau software.
A dashboard. Okay.
This is where all the rich insights from both the qualitative textual analysis in phase 1 and the quantitative number crunching in phase 2 come together in one visual, user-friendly place.
So what's the core purpose of this dashboard? And maybe more importantly, how does it actually empower the users, the policymakers, the program planners, the funders in their day-to-day work fighting AMR?
Its main purpose is to allow for easy visualization and, crucially, comparison. Comparison of AMR intervention contexts, components, and potential impacts across different countries.
So users can see what others are doing.
Yes, and how it might relate to their own situation. The tool aims to empower users to benchmark their own country's AMR strategies against others, compare clusters of countries maybe by geography or economic status,
Interesting.
enable really rapid knowledge sharing among strategic and operational folks, display visualizations showing trends over time, how things have changed year by year.
Like seeing if policies corresponded with changes in AMU or AMR.
Potentially, yes. It can show the distribution and allocation of those ERIC implementation strategies across different countries and years. It allows users to slice and dice the data, visualize multiple dimensions describing interventions, and make comparisons across different countries, time periods, or specific implementation parameters.
So it's really designed as a decision support tool.
Absolutely, making complex data accessible and actionable for decision-making.
And I really like hearing that the design process itself wasn't just top-down, it was user-centric.
Yes, very much so. The dashboard development is described as following a participatory, iterative process. It's being driven by engaging directly with potential stakeholders, the policymakers, the planners, and understanding their needs.
So it should actually be useful in practice.
That's the goal, to ensure it's practical, intuitive, and genuinely relevant for decision makers in all sorts of settings, from low and middle income countries to high income countries.
Now, if we step back and connect this to the bigger picture, this study seems to speak directly to the broader issue of global health inequities, doesn't it?
It really does. The fact that the burden of bacterial infections, and therefore AMR, falls so disproportionately on certain parts of the world is a stark symptom of these underlying inequities.
Right.
There was a recent very influential Lancet series that strongly advocated for refocusing the global AMR agenda much more explicitly on low and middle income countries where the impact is often greatest.
And this research helps do that.
Yes, by providing tailored insights and comparative data, it directly supports understanding the challenges and potential solutions in those specific contexts where support is often needed most.
And one of the really striking things highlighted is the potential power of prevention. The study points to evidence showing preventative measures could make a massive difference, right?
Yes, this is a critical point. The evidence is robust. Fundamental public health measures, things like ensuring access to safe drinking water, effective sanitation and hygiene, widespread vaccination coverage, and strong infection prevention and control practices in healthcare
Or
facilities.
basic stuff, almost.
Foundational public health, yes. These approaches could prevent over 750,000 deaths associated with bacterial AMR each year, specifically in low and middle-income countries.
Wow, 750,000 deaths.
It's an enormous potential impact. And, importantly, it relies on strengthening existing systems and prevention, not solely on discovering new drugs, which is also needed, but faces huge challenges.
And it seems the SPAARTA protocol is also looking beyond just AMR for lessons, trying not to reinvent the wheel.
Exactly. Which makes so much sense, doesn't it? Why develop entirely new systems and approaches from scratch if similar challenges have been tackled before?
Right.
The study explicitly aims to learn from other major global health battles, like the fights against tuberculosis, HIV/AIDS, where, by the way, rising drug resistance is also a growing concern.
A parallel problem.
Yes, but also looking at lessons from managing mental health challenges, tackling climate change impacts on health, and responding to epidemics like Ebola and, of course, COVID-19.
So what's the goal of looking at these other areas?
The goal is to identify effective strategies, avoid repeating past mistakes, and potentially build more sustainable health systems by integrating AMR efforts with existing successful programs where possible. It's about efficiency and long-term impact.
This research also seems positioned to answer some really key questions that bodies like the United Nations General Assembly have raised about AMR action plans. What kind of critical questions are we talking about?
We're talking about the really practical, high-level policy questions. Things like, how can countries effectively mobilize domestic resources for their NAPs, not just rely on external aid? How do we ensure NAPs are properly costed out and then monitored for progress?
Crucial for accountability.
Absolutely. Also, how can we genuinely enhance collaboration across different government sectors, health, agriculture, environment? And how can countries meaningfully engage the private sector in the AMR response?
Big, tough questions.
Indeed. And SPAARTA aims to provide data-driven evidence to help countries find answers to these critical queries, enabling smarter investments and more effective policies.
So if you had to pick maybe one standout strength or breakthrough capability of this whole SPAARTA approach, what would it be? What really sets it apart in trying to tackle AMR?
That's a tough choice. But I think I'd have to say it's the powerful combination of things. It's the use of rigorous, multidisciplinary frameworks like ERIC.
The 73 strategies.
Right, which provides decision makers with this comprehensive compendium of evidence-informed options. But then it's coupling that deep qualitative understanding with the sophisticated quantitative analysis.
The impact measurement.
Yes. And then packaging it all within those powerful, comparative, interactive dashboards. That whole package, the systematic mapping, the robust impact analysis, and the accessible visualization tools allows for an incredibly detailed, nuanced, and actionable understanding of AMR efforts globally.
Moving beyond just anecdotes or single case studies.
Exactly. Towards data-driven insights and genuine benchmarking, it feels like a truly comprehensive roadmap.
Now, fairness requires acknowledging limitations. Every study has them.
Yeah.
What are some of the limitations for SPAARTA that they've openly noted?
They are quite transparent about this. A primary one, which is common in global health research, is dealing with the existing gaps and inconsistencies in AMR data collection across different countries and over time. Data quality is still a challenge.
Okay, relying on available data.
Yes. Also, the initial sample of 17 countries, while diverse, doesn't include countries currently experiencing active conflict. These places face unique, complex challenges in implementing any health program, including AMR NAPs, which might not be fully captured in this initial analysis.
That's an important point. Anything else?
And just a practical point. They note some potential customization constraints with using Tableau as the dashboard platform. While it's powerful and widely used, there might be some specific analytical visualizations that are harder to implement compared to fully custom-coded solutions. But this is often balanced against Tableau's ease of use and maintenance for a diverse range of users.
Okay, understandable trade-offs. So bring this all together then. What does this deep dive into the SPAARTA protocol really mean for you, our listener, and for the broader fight against AMR globally?
Well, I think it reveals this really systematic, transparent, and quite innovative approach for countries to genuinely understand where they stand with AMR, to benchmark their strategies, learn from others, and importantly, move beyond just having a plan on paper.
Towards action.
Towards actively implementing, monitoring, and refining that plan using precise, data-driven insights. It's fundamentally about empowering policymakers and planners with actionable knowledge, speeding up the sharing of what works, and ultimately building more resilient health systems around the world that can actually withstand this growing threat of AMR.
All right, let's end with a provocative thought for you to mull over. We've seen clearly today that the battle against AMR isn't just a medical or scientific challenge, is it?
Not at all.
It's deeply intertwined with these broader societal and systemic factors, everything from a country's economic condition to its basic infrastructure. So connecting this to the bigger picture, here's something to consider. How might factors that seem, on the surface, completely unrelated to medicine, things like access to quality education, or the level of political stability, or even the efficiency of a nation's food supply chains, how might those kinds of factors profoundly impact a country's ability to successfully tackle a complex global health crisis like antimicrobial resistance? Something to think about.